Good morning. Welcome. Thank you for joining us for this presentation of our speaker series, Toxicology and Societies, the Impacts of Chemicals in Our Lives. I'm Ruth Sofield, a professor of environmental toxicology and chemistry at Western Washington University. My co-host, Ian Moran, is a visiting assistant professor of environmental toxicology at Western Washington University. Hi, Ian. And Tracy Collier, a toxicologist who's retired from NOAA's Northwest Fisheries Science Center and continues his work as a consultant. Hi, Tracy.
Hey, Ruth.
We would like to begin by acknowledging that we at Western Washington University are on the ancestral homelands of the Coast Salish peoples who have lived in the Salish Sea Basin throughout the San Juan Islands and the North Cascades watershed from time immemorial. Please join us in expressing our deepest respect and gratitude for our Indigenous neighbors, the Lummi Nation and Nooksack tribe, for their enduring care and protection of our shared land and waterways. And now I'd like to go over a few logistics. We will save questions for the end of the presentation, but you can use the Q&A feature on your screen at any time. You will be muted throughout the presentation, so we will use this feature to interact. The focus of our speaker series is to provide understandable examples of how events with a toxicological component have consequences to people and societies. Today, we are delighted to welcome Tracy Woodruff, the Allison S. Carlson Endowed Professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at University of California, San Francisco, and the Director of the Program on Reproductive Health and the Environment. Today, she will present on how exposures to environmental chemicals contribute to health inequities and chronic disease. Welcome, Dr. Woodruff.
Thank you. And I will share my screen. All right, how's that look?
That looks great. Thank you.
All right, thank you. And welcome, everybody. I am going to talk about environmental chemical drivers of health inequities and chronic disease. And I am the director of the Program on Reproductive Health and the Environment, and also a P30 NIEHS Center, the Environmental Research and Translation for Health Center. And the goals of our work is to improve environments, to make them healthier by reducing exposures to toxic chemicals. So we have 3 prongs to our program. We conduct targeted research to answer important questions, to lead to improved clinical care and just public policy that will reduce harmful chemical exposures. And I have nothing to declare. So I'm going to start with a provocative question, and maybe you know the answer to this, but what is the leading cause of death worldwide? And many people often think of communicable diseases like AIDS, tuberculosis, and malaria, or malnutrition, or maybe violence, drug, alcohol use. But what's really important for this work is that it turns out that total pollution is the leading cause of mortality worldwide. And this is primarily due to air pollution, water pollution, lead, and toxic environmental exposures. And smoking and secondhand smoke is a close second. And I want to also note that total pollution, the burden of mortality, premature mortality from total pollution, is 3 times greater than AIDS, tuberculosis, and malaria combined. And this was done in a series of articles published in Lancet. I'm showing you the data from the second in this series, which was led by Dr. Fuller. And I think what's remarkable about this is 2 items I'm going to call out, which I will talk about in the talk, which is that over the 2 time periods, this one was published, I think, maybe last year, and then a few years before this, is that there has been little progress against pollution overall in addressing the overall effects of pollution on mortality and the chronic burden of disease, and that it affects particularly low-income and middle-income countries most severely. And then the other component of this, which wasn't produced in this update, was a more robust attempt to account for chemical pollution effects on mortality, but unfortunately, it's very difficult because there's a lot of data lacking around toxic chemical exposures and their contribution to health and health inequities. And the article points out that urgent attention is needed to prevent pollution-related diseases, emphasizing air pollution, lead poisoning, and hazardous chemical pollution. And so it's really important to think about the role of chemical and toxic and air pollution and toxic pollution in terms of what we're seeing in the shift of disease globally. So it used to be that the communicable diseases was the highest share of the burden of the global burden of disease back in the 1990s, about 40, almost 50% of the global burden of disease. And what we've seen just over the last 20 years is that that there's been an increase in the contribution of non-communicable diseases. So these are things like cancer, respiratory, cardiovascular, neurological, and metabolic diseases to the total estimated global burden of disease worldwide, to the extent that it now comprises 64% of the estimated global burden of disease. And so this is a dramatic increase in terms of the shift from communicable to non-communicable disease since 1990. And so we have to look at this. Can only be due to factors in our environment that are causing this shift, because it's not going to be due to genetics. So that is the driving basis of our work, is to look at the role of toxic chemical exposures in terms of contributing to this shift in increasing non-communicable diseases. And so before I go into the rest of the presentation, I want to talk about the role of anti-racist research. And I really liked this series of articles that came out around 2020, 2021 about what is anti-racist research. And racist research, and this is a quote from an interview with Ibram X. Kendi by Ezra Klein, but it's part of a work that he's done. And that racist research historically has posed the question, what is wrong with people in terms of, for example, their genetics or their lifestyle? Whereas the anti-racist research asks a different question, which is, what is wrong with the policies? Or another way to think about this is, what is wrong with the environmental factors that influence people's health? And that policy change has been the key to an anti-racist change. So what we really want to focus on is the outcome. If a given policy or action reduces racial inequality, it is an anti-racist action. If it increases it, it is racist. So when we think about looking at our research question and then how the science is used in decision-making, particularly around public policies that influence everyone's exposure, are we addressing the environmental exposures that lead to less health inequities rather than more? So this is from a quote from the former director of National Institute for Environmental Health Sciences, which probably is familiar to the people attending this call, is that we live in a chemical soup. And that is because there is a large number and amount of industrial chemicals that are produced annually. And this is data from the U.S. Environmental Protection Agency, which I think is remarkable because most people don't know the extent to the amount of pounds that are being produced or imported into the United States. And this estimate is recent, and it's equivalent to a little over 9 trillion pounds of chemicals a year, which comes out to about 30,000 pounds of chemicals produced each year in the US per person. So this isn't, because there's such a large number or amount of chemicals being produced, it's inevitable that we are all going to be exposed to these chemicals. And these include chemicals that, and actually this data has been updated to 2020. These include chemicals like perfluorinated chemicals, flame retardant chemicals, phthalates, phenols, all used in the many different types of everyday products that we come into contact with. And I think it's also really important to highlight the connection between these chemicals that are being produced and fossil fuels. So the fossil fuel production in the United States, including natural gas, coal, et cetera, is used as the primary means of production of industrial chemicals in the US. And that has increased dramatically with the increasing use of fracking to extract natural gas from the ground. A component of this extraction comes off and is used to make these different intermediate products that become the many different types of chemicals that then come into the products that we are using or come into contact with in our daily lives. So this includes a lot of plastic related products. And so you can see everything from the food packaging, clothing, cars, transportation, home, adhesive coatings, et cetera, come originally from this petrochemical connection. I just want to also point out that ExxonMobil, which we probably know as the producer of gas and oil and et cetera, is also the primary producer of these petrochemicals, including plasticizers like phthalates, and that the production of ethylene as feedstock is more lucrative, as feedstock for plastics is more lucrative than the sale of methane and ethane for fuel, heat, or electricity. So there's a large monetary incentive to be producing these petrochemicals from these natural gas origins. And these are also the same origins that contribute to climate change. So it's really important when thinking about climate change, one of the sources of climate change produces, which is the fossil fuel industry, produces both these CO2 emissions, but also are a source of petrochemicals. So the increase in chronic disease is concurrent with what we're seeing in terms of increases in global production capacity. This is data from 2000, and you can see that there's been global production increase in chemical industry and in plastics. There's a large investment in plastic production that has been going on since 2000 and is projected to increase greatly over the next 30 years. And this is leading to increases in a number of different feedstock products that feed into many different types of chemicals, including these different ethylene, propylene, butadiene, et cetera. And now the estimates, and this is from a paper that has looked at the various planetary boundaries, that these are the planetary boundaries are defined as conditions that, if exceeded, put the stability of the human population as well as environmental population at risk. So for example, one of the planetary boundaries is climate change. And you can see that, if we are in a stable condition, we're in this green circle here, but once the measurements exceed this planetary boundary, we're at risk of ecological challenges, or maybe even collapse. And so as climate change is obviously one area where we've exceeded the planetary boundary. There's also nitrogen and phosphorus, ocean acidification. And the one that I want to point out here is that the recent estimates have come out that one of the planetary boundaries is also related to chemical pollution, which is named novel entities in this paper. And that recent estimates find that the chemical pollution has exceeded the planetary boundaries for a safe and healthy environment. So chemicals are used in many different places that we can be exposed to in multiple ways. So we have we're exposed to chemicals in our drinking water, our food supply, through air pollution, through the many and different types of products that we come into contact with, whether they're personal care products or other types of products, or in the materials that are used in our offices and buildings and homes. And then there are important exposures that occur at higher levels due to occupational exposures. And all of these exposures occur continuously over time, to the extent that we are continuously exposed to toxic chemicals starting at conception. So this is from work that we've done. It's a little bit old, but it's still true that the studies have shown through biomonitoring, which is measuring chemical signatures in biological samples, including blood and urine, that there are many different chemicals measured in people. In this study, we used national data that's produced by CDC and found that there were over 43 chemicals. There are 43 chemicals that were found in every pregnant woman that was measured, which was representative of U.S. pregnant women in the United States. And there were more chemicals measured in different subpopulations because not all of them were measured ubiquitously. And these are chemicals that I've already previously talked about, which are things like perfluorinated chemicals and phthalates, and some of them are chemicals that persist in the environment and are measured many years after they're banned, including PBDEs and PCBs. And what's really important about these exposures that occur during these this life stage is that, or during pregnancy, is that this very important periods of development that are occurring, to which if you have environmental perturbations that can significantly and permanently alter the trajectory of development, which can manifest in adverse health effects either at birth, childhood, or even into adulthood. And so the National Cancer Institute has talked about this in a report that they did on environmental carcinogens, and noted that to a disturbing extent, babies are born pre-polluted. And that's because exposures during pregnancy cross the placenta and have been measured ubiquitously also in the cord blood or during fetal development in the developing fetus and infant. So what about environmental exposures and pollution burden characteristics? So pollution exposures are unequally, and chemical exposures are unequally distributed in the population. And this is well illustrated in the data repository that California keeps called CalEnviroScreen. CalEnviroScreen, which is accessible to anybody in the public, measures various measures of pollution burden, including air pollution, drinking water contaminants, pesticide exposures, as well as a location near solid waste facilities, hazardous waste facilities, and cleanup sites, as well as the combination of characteristics that can put people more at risk from exposures to pollution sources, including whether they have an existing medical condition, such as asthma, cardiovascular disease, and socioeconomic factors that can increase risk due to psychosocial stressors that can create a burden on these populations. So educational attainment, poverty, food insecurity, and linguistic isolation. And as you can see that in the distribution of both environmental exposures and the factors that contribute to health inequities, such as lower SES, are concentrated in certain populations. For example, here in California, we see that areas in the Central Valley, as well as some locations in San Francisco, LA, and then this eastern part of the lower California, can have a combined excessive burden of both pollution as well as social vulnerabilities due to poverty and food insecurity and higher disease mortality. So this can lead to health inequities in the population. And we also know from biomonitoring studies, so similar to the biomonitoring studies that we look to see, well, what are the types of chemicals that occur during pregnancy? We also know that those exposures are unequally distributed in the population. So this is from data that we published as part of the National Institute for Health Environmental Challenges, the ECHO program, which is a national NIH consortium to evaluate environmental influences on child health outcomes. And we did a study of what would be considered more novel chemicals that have not been biomonitored during pregnancy, including to chemicals that are commonly found in personal care products related to plastics, may be found in your home, or can occur in fast food. So these are things like plastic-related chemicals, so phthalates related to plastic. Some of them are pesticides, and herbicides, bisphenols, and benzophenones, which are found both in plastics and can be found in personal care products. And what we found in this study is that those pregnant participants that identified as Black or Hispanic had higher exposures to many of these different types of chemicals compared to their white counterparts. So here we see these up red arrows mean that their exposures are higher compared to the white counterparts for these bisphenols, also these neonicotinoid pesticides, and then these parabens and phthalate alternatives. And you can see it's pretty universal across, or a majority of these chemical exposures. And so this means that we can be seeing a health inequitable contribution due to higher levels of these chemical exposures, whether it comes from external sources or is internally measured. And so many of these chemicals, let's talk about, can, as I said, can have adverse health effects on development and pregnancy. And many of them are also known as endocrine disrupting chemicals. And just to note that these endocrine disrupting chemicals, again, BPA, pesticides, phthalates, perfluorinated chemicals, can adversely influence many aspects, for example, female reproductive health of the reproductive health system. So we have both universal exposures, multiple chemical exposures, and that these exposures are higher in of communities of color. And so we also know that these communities have higher rates of many of these different types of chronic adverse health conditions. So there's an important role that these chemicals can be playing in aggravating health inequities. So as I mentioned, that these again, that the petrochemicals origin is from natural gas or other fossil fuel extraction, and that these exposures are modified by non-chemical measures, so SES, discrimination, racism, as well as intrinsic factors, age, genetics, and sex, to lead to an increase, can increase the risk of these adverse health effects. And just to illustrate that and it's really important for this, because a lot of the approaches that many of the approaches that we use to take the data to make a regulatory or policy decision does not fully account for the different factors that can that can influence health outcomes. So typically in the regulatory setting, for example, the baseline risk is considered for an individual chemical exposure. But when we look at the factors such as intrinsic risks like age and genetics, the number of people who could move from no adverse to adverse can increase. Age is sometimes accounted for in regulatory decision making. But the other factors, such as these extrinsic factors, stress, racism, poverty, which can have been shown to increase, can lead to chronic psychosocial stress, which can increase risk of adverse health outcomes. The intrinsic, extrinsic, and baseline risks, which can move more people into the adverse health outcomes, is not fully accounted for in the regulatory system. So there has been a lot of discussion about the cumulative impacts of the totality of combined exposures to chemical and non-chemical stressors. This is from a very recent paper published by EPA. EPA is starting to look at how these things interact together, but there's still more work to be done to fully account for how these different factors can be contributing to health inequities. And as I mentioned, we're seeing this as a large toll on our health, as we're seeing an increase in a number of these different chronic or non-communicable diseases that are also inequitably distributed. And particularly, I want to point out that we're seeing a large increase in factors like there's increasing childhood cancers, ADHD, and autism that could in part be due to toxic chemical exposures. So to give this a more specific example, I'm going to talk about phthalates. Phthalates are a group of plasticizer chemicals. They're used in, and I think they illustrate both the extent to which of exposures, the ubiquity of exposures, and the fact that it comes from because they're used in so many different types of products, as well as the inequitable distribution of exposures. So phthalates are a group of chemicals that can that are found used a lot in plastics. They can make hard plastic more pliable. So they're used in many different types of building material, vinyl flooring, wallpaper, paint, glue. They're also been found in baby products. They're in automobiles, coatings of pharmaceuticals, medical equipment. They also can be used to convey scent. So there are a lot of use in cosmetics, shampoos, lotions, and scented products. So everywhere. And because of that, we measure phthalates ubiquitously in the US population. Additionally, phthalates are also an endocrine disrupting chemical. Phthalates have been shown that they can disrupt androgens or testosterone, increasing that. Then they can do that by blocking synthesis of androgens and testosterone. And this is particularly important during development because there's an increase in testosterone that signals the development of the male reproductive system. So these, and then also testosterone and androgens are also important for other, or phthalates can also influence other aspects of development as well as normal functioning. And there's been a lot of studies on phthalates, and there's also been systematic reviews of the relationship between exposure to phthalate and multiple different types of health impacts. And we now know that male reproductive toxicity can be influenced by phthalate exposures. It also can increase the risk of preterm birth and can also increase the risk of metabolic disorders, including insulin resistance and diabetes. We'll note that, for example, this is increasing in the population. It's also been suspected to increase the risk of spontaneous abortion as well as neurodevelopmental harm. There's also racial disparities in phthalates exposures. So, and one important component of this is that that beauty-related products that are and primarily used by Black women have 30% higher exposures. There also is phthalate exposures can be higher in processed food or food purchased outside the home, and this can lead to racial inequities in phthalate exposures. And we see this from a series of really excellent studies, which we pooled data from 16 cohorts, which were looking at or examining phthalate exposures during pregnancy and pregnancy-related outcomes. So in this pooled cohort, they had 16 cohorts, which is about 6,000 births. They were in this study, they looked at the relationship between exposures to phthalates and preterm birth. And I want to note that one important finding from this is that you can look here on the right, and you can see the they show the phthalate measurements in the different groups of the participants. So they have Black participants is the orange dot, Hispanic is the triangle, and Asian is the square. And you can see from basically all of these phthalates that the exposures among the Black participants and the Hispanic participants were higher than the Asian. And these were actually, I'm sorry, this is in comparison to the whites. So Asians were pretty similar to whites, but Blacks and Hispanics had, in some cases, 150% more phthalates in their bodies than their white counterparts. And then this is the relationship between phthalates and preterm birth. So you can see that in general, phthalates are related to the higher the levels of phthalates, the greater the odds of preterm birth, and this is exposure to the mixtures. Another important factor when thinking about regulatory settings for looking at chemical exposures is that the exposures to multiple chemicals can have a greater effect than the individual chemicals alone. And this, I think, well illustrates that the individual relationships between the phthalate and the outcome are around here. But when you look at the mixture, you get a greater effect than compared to the individual exposures. So what about the relationship for health inequities? Well, they did this is a separate paper. Oh, dang, I didn't put the reference. Sorry. This is published in Environmental Health Perspectives recently. And what they did was a hypothetical intervention, which is really interesting. They said, well, if we took this level between, you see up here, the Black participants, and lowered them to the white participants level for the Blacks and the Hispanics. So they took the orange line and moved it down here. And the Hispanics moved it down here. What would be the effect on the racial inequities in preterm birth? And so this is, so if they took the Black Hispanics here, this was the relationship between phthalate exposure and preterm birth. It was about up here. And then they, after the intervention, you can see, so they had 125 per 1,000 births, preterm birth, but it was reduced to be similar to the whites after they did this hypothetical intervention of reducing the phthalate exposures. It didn't make as much difference in the Hispanic population. The greater difference was in the Hispanic, non-Hispanic Black population. The point being that the driver in preterm birth difference, the health inequity in the preterm birth difference for the Black population could largely be explained in this study by the phthalate exposures. So if you imagine that this could be extrapolated to other health inequities, that it just demonstrates that chemical exposures could be a really important driver of health inequities that we're seeing in the population. So what is our strategy for, I'm going to talk a little bit about what we do to address how to take this, lots of this really important data and to move it into making a difference about people's exposures. So I think I work in a primarily UCSF is well known for its clinical care, where they do a lot of treatment for people who are very sick. And we work at the opposite end of that, which in this cartoon says, I'm afraid there's not much I can do for you now. You should have come in sooner before you got sick. So our goal is to have less people come into the doctor and have this situation happen. So our model focuses on looking at across the science that informs the links between exposure and disease. Work with clinical healthcare professionals who are also becoming more concerned about the role of environmental chemicals, and in part due to they're seeing in their practice these increasing number of people with a complex, unusual, or even higher prevalence of chronic conditions, and to work with policymakers who are trying to address the role of environmental chemicals in health outcomes. We also do primary science to answer these questions and then translate that science to improve medical curriculum, healthcare professional societies, and also to focus on how to translate this information to support hazard and risk assessment and decision making. And then that will lead to an integrated approach where healthcare professional societies are recognizing the role of the environment, and they are also important partners for promoting improvement in public policies that will reduce these environmental impacts. So this is an example of work that we've done with the International Federation of Gynecology and Obstetricians. This is an umbrella group that represents obstetrician and gynecology health professional societies in over 130 countries. They issued this consensus statement. We worked with them on this consensus statement a few years ago, and the goal was, they looked across this and said that the role of the environment in adverse reproductive and developmental health outcomes is important, and that they identified 4 strategies to address it. And first one was to advocate for policies to prevent exposures to toxic environmental chemicals. And that is because the role of the individual in preventing many of these exposures due to the ubiquitous use of them in many places that we have no control over is best addressed through public policies. And it's also consistent with the anti-racist agenda, which is that the research informs the policies to reduce exposures. To work to ensure a healthy food system, make environmental health part of healthcare, and champion environmental justice. And so policy actions we know now can make a demonstrable difference in people's exposures. Just go back to phthalates. Phthalates, a certain numbers of phthalates were banned around 2000. These are the levels of phthalates measured in the population through the CDC data. And you can see that after the ban, the levels of this particular phthalate that was banned went down, showing that taking phthalates out of the marketplace through regulation matters. Some of the phthalates were also a target of market-based campaigns for environmental health groups, and so phthalates were removed from a number of different personal care products. You see this also go down. Unfortunately, these phthalates were banned, but they were replaced with a different phthalate. And what you see is that those phthalate levels have gone up in the population. So it shows that policies are effective, but they need to be also comprehensive in order to ensure equitable distribution and not being replaced with toxic alternatives. So one other thing we like to recommend is that people vote, and that the clinicians have been organizing themselves around using their clinical encounters as a way to register to people to vote. And there's some great work on this. And finally, I want to talk about that, that the role of improving the environment is a win-win for the economy as well as health. This is the estimates of the impacts, of the Clean Air Act, which is reduced because of the Clean Air Act. We've seen a reduction in common air pollutants, 6 common air pollutants. This is actually an underestimate because EPA just announced new standards, but it's been a $2 trillion in savings, while at the same time growing domestic care products, increase in population, and energy consumption. Okay, CO2 emissions have gone up, so we're still dealing with that. But you can still have a very healthy economy and a population while at the same time reducing exposures to toxic pollutants. So just before I end, I want to say that one of our goals with our work at UCSF is to link in scientists who are interested in engaging in public policy to amplify their science and decision making. We run the Science Action Network, and we offers collaborative opportunities to participate at any level, whether it's attending webinars that we host on science policy issues, contribute to public comments, or possibly just see what's going on in this area by receiving our bi-monthly Science Policy News Digest. We have over 200 scientists from 9 countries, 22 states, and 58 universities, and you can sign up on our website. So in conclusion, environmental chemical exposures are widespread and adversely affecting health inequitably, and that it's really important for scientists to be engaged to move the needle in terms of systemic change, which is actually completely possible, but takes our engagement and time and persistence. So I want to thank everyone at UCSF who works in our group. We have many people who make this all work happen, including our funders. And for more information, you can follow us on our website or our social media channels. Thank you.
Thank you so much, Tracy. There we go. Hey, thank you so much for that. I'm going to start asking some questions, and we'll see if the audience contributes some. I just out of maybe just interest, I'm curious how we measure infertility, and do we feel like we have a good understanding of like those?
Oh yeah, I didn't talk about that. Actually, that's really interesting. So there is So the National Center for Health Statistics carries out the health interview survey. The health interview survey is a national representative survey where they ask people about various health conditions. And every, I think it's either 3 years or 5 years, they do a reproductive health survey. And in that survey, they measure different measures of fertility and fecundity, fecundity being um, a measure of your capacity to maintain and achieve a successful pregnancy. And what we've seen is, and I didn't present the data because it's kind of a little bit old, but we've been recently updating it. But we've seen an increase. So there's a lot of, if you read the popular news, people are like, oh, population decline, and oh, it's because women, I feel like a lot of it's around blaming women, but it's because women are getting older and they're more educated. But I think if you look at the data, it turns out that the rates of fecundity problems have been also increasing in young women who do not have who are not have a challenge with fertility due to age. So I think that this is an increasing issue, and it's not well covered in the news media. So you can measure it, and it's done in that survey.
Okay. And what about, so, there's been a lot of news about declining sperm and
Oh,
my,
yes.
is that, I don't study that, but my like kind of dated understanding is that as with anything, there's kind of mixed data. What's the
Well,
current take on that?
that's actually interesting too. The data that so Shauna Swan has done, been a leader in this analysis, and they did a meta-analysis. I think they published one like 5 years ago that showed where they aggregated the studies that have been published across multiple sites, and they saw a 50% decline in sperm quality and mortality and sperm, I'll just say loosely sperm quality over the last, I don't know, 20 to 50 years. They then have since updated that meta-analysis, which included more studies and finding very similar results. So I would say that data, I mean, and if you look into that data, some of it is, there's certainly variations in how people measure it, but there are definitely studies within there that people are measuring. Like, for example, there was a study that looked at testosterone levels in men, but that over time, we've also seen a decline in that. And that was actually, it's interesting. I was talking to someone that was like done by the same lab, by the same person measuring it over the time period. So in some cases, it's not, certainly there's going to be some variation due to, who's doing the measuring and measurement capacity, but a 50% decline is, plus it was a meta-analysis, it's not likely due to that. So,
Right. Okay. I have there's some questions I want to get to, and I'll stop doing mine. But I want to do one of mine still. Uh, I am interested in helping people who don't think about pollution as an issue to see
mhm.
that it does matter. And I think it's been hard because there are, it's challenging to link chemical exposure to something like a chronic disease, which is what we think about now. And so there's, different ways to think about how to do this and how to communicate what we know and what we know about impacts of chemicals on humans in this case. Um, and so I've often thought about, we want to walk the line. We don't want to scare people inappropriately, but we also need to help understand the the true relationships and what's happening. So I'm curious what your thoughts are on how you think about, or if you bump into this idea that pollution doesn't matter, I'm not impacted. Do you bump into that? And if so, what's your kind of strategy for thinking about it and talking about it?
Well, so first of all, I think the data are pretty unequivocal. I really like to show pollution matters. Even if you're thinking about air pollution, it is a huge burden of disease. It's the biggest in the world, really. So I guess now, so that's one factor. I think there's a lot of chatter around, oh, I didn't have that in here, but there's a lot of chatter around, oh, well, these chemicals, they don't really matter. So, um, I would say that on the individual level, the risks can be modest. What's key is that everybody's exposed to these chemicals. So on a population level, even a modest risk factor results in a very high burden of disease. That's why pollution, I didn't show these slides, but there's an estimate that shows between tobacco, air pollution, and ultra processed food, the environment is the biggest, by far the biggest contributor to the global burden of disease. So, and then for the chemicals, I think it depends. You know, we offer advice we do both offer materials for clinicians to give to their patients, or we offer just direct patient or public advice on our website under Toxic Matters. And I would say we speak about it, you know, simply. I mean, these have an ability to increase your risk. You have capacity to do some reductions to these chemical exposures through, you know, choices that you make in your life. But the biggest contributor to making a change is really being by the government. And I would say that we've done a public opinion survey on this topic with both focus groups and 1,000, and working with Celinda Lake, which has done a lot of opinion and pollster surveys. And by and large, the public is very attuned to that toxic chemicals could be impacting their health. And they're very attuned to that this is an important issue that they think the government should deal with. So I feel like really where we're at it is like dealing with with our science, clinical, maybe and government partners. Two things that we've done in this. One is we've bolstered the ability to make a conclusion from the science. So we started 10 years ago this systematic reviews in environmental health, and so now realize it's both a rigorous, transparent approach to how you evaluate the evidence that comes up with a bottom line summary. So we can confidently say, like those conclusions I made about phthalates, those are based on best approaches, and they're both evidence-based and also provide a bottom line summary in terms of their relationship to health effects. And we can say that confidently about a lot of different chemicals. I think where we're being pushed back is really the people who make the chemicals have a high financial stake in the outcome of what we find. And so they do spend a lot of time, or we know that there's documented ways that they look to undermine the science and confuse the public discourse on this topic.
Excellent. Okay, so we have questions coming in. So one, how has work focused on non-communicable disease, such as yours at UCSF, been affected by the COVID-19 pandemic and concerns about highly pathogenic bird flu, for examples?
And concerns about, can you say that again?
How has work on non-communicable disease, such as yours?
By COVID. Yeah, that's interesting. Well, that's true. I think I have to look and see if that burden of disease covers the COVID years. And then what was the latter part about how people?
Well, and they gave another example. In addition to COVID, another example would be bird flu.
Bird flu, yeah. I don't think bird flu is
pathogenic bird flu. So I think,
well, okay, so the data that I showed on communicable versus non-communicable disease is all tracked by, actually it's in your state. The University of Washington has the, what's the Institute of Health Metrics? Can't remember exact name. And the Chris, what's the last name? Anyway, I'm not gonna remember that right now, but the point being that that's all being tracked through the institute at the University of Washington on health metrics, and they have been tracking the contributions to overall global burden of disease from both communicable and non-communicable diseases. So certainly COVID had an uptick. Did it overtake the bump that's come up from chronic? So there's a difference between the premature mortality, which is one item, and then the burden of disease, which there's different factors that go into calculating that. So certainly COVID was important, but I don't know. I can't say whether it's overtaken the non-communicable diseases. I doubt it, because we've now had 2 years and 3 years since then. So
yeah. Okay. I think this would be a quick one, but just clarifying. Somebody was curious about the use of environmental chemical exposures. Their experience in your example of phthalates indicates that a lot of exposure is from foods and consumer products and not the general environment, air, water, and soil. Why is the term environmental chemical exposures used for these types of exposures?
It's interesting. So you can be right. It's true the primary source of phthalate exposure comes from food. So, which I would consider one very important route of exposures to chemicals. But you can also be exposed dermally from your products. You can also be exposed through dust, and dust can be inhaled. So there's a really excellent meta-analysis that shows that chemicals love to hang out in dust. So dust is like an aggregate place for chemicals to spend their time. So people are exposed and then get exposed from the dust, either breathing it, so that's an air pollutant, or gets on their hands and food. So that again is food. Maybe phthalates aren't really in water, so that's fair point. And then it's used, phthalates are in vinyl flooring, or not, maybe not so much anymore, but they're in vinyl flooring, they're in adhesives, paint, so they can be off-gassing. So that's another source of exposure. There was some interesting studies in Denmark, vinyl flooring and childhood asthma, and showing a relationship between houses with vinyl flooring and kids having childhood asthma, and that could be from inhalation exposure. So I don't know. I think they're probably all contribute something.
Cool. Okay, the person who asked about the pandemic clarified they're wondering about political and funding situation as we experience pandemic. So has the communicable diseases impacted like how we think about and how your work is your work?
Well, I would say that, yeah. I mean, I think it's really challenging. Research funding for just environmental chemical exposure has not kept pace with the problem. And that's in part, I mean, I think there's many factors that go into that. Part of it is, driven by, the focus on communicable diseases, which certainly was important in the 90s. Maybe it's less important, so we have to switch what we're looking at. I think there's also a lot of promotion of individual focused risk factors. A lot of studies are on what did you eat and did you exercise and that kind of thing. And that is I call the kind of the blame the victim studies, because it's really, a lot of people don't have access to high quality food. They don't have access to, the structures and their way their environments are set up are not conducive to them having movement or exercising or whatever. So that's one thing about that. Then the second is it sort of distracts also from focusing on these environmental risk factors, or even things like ultra processed food, which is also a really big problem. So, and some of that, you can trace that line of promotion of it's the blame the victim research to a lot of the tobacco industry. So UCSF is home to a large industry archives, starting with internal documents from the tobacco industry, and research from that has shown that the tobacco industry, along with other industries, promote a blame the victim approach to research because it distracts from looking at these risk factors that are really probably mostly driving most of the problem.
Yeah, and so what like if we want to kind of, that was a question somebody had, how do we kind of change the narrative about blaming the victim? Is there like I would guess you've thought about that. Like, is there something that we can do?
Well, I mean, yeah. So the kind of the ways that we deal with this, some of the approaches we use to address this first is we change our language. We don't say a lot of language around these risk factors are like lifestyle. We don't say lifestyle. We say individual level factors, or factors that are about the individual and not about the systems. I think there's a lot of language notes that kind of keep people into thinking it's your fault, and not that you don't have some control. I don't want to say that, but there's a lot of things that are outside your control that are being pushed on you that you can't control, and that is not your fault. And I think a lot of the language we use about that tends to focus on you as the individual rather than the systems that are set up around us. So that's one way we deal with that. I mean, we also, whenever we give out our recommendations for things you can do to reduce your environmental burden load, we also talk about the role of connecting to voting. That's why we always say you should vote, because that's a really important way to signal to your your representatives that you think the government should be acting or joining groups or whatever, to be that there's ways that the government is an important role to play in what you're exposed to in terms of environmental chemical exposures. And then we have a new initiative, and you can check out our blog, which I didn't put on here, that is talking about what's the role of the industrial sector or corporations in influencing our health outcomes. So kind of known as the commercial determinants of disease, calling it corporate influences on health. And that, I think, is really important for us to acknowledge their role in undermining the science, and also public discourse that contributes to our inability to recognize the true risk factors for health outcomes.
I think, thank you. We're going to end with this question. How have we allowed such a negative experiment? What are the potential long-term implications on human evolution? So that's,
I know, I love that global experiment. I know it's like everyone's like, oh, let's not experiment on animals. Okay, we'll experiment on ourselves, which is exactly what's happening. So I would say this is where we're really focused on the chemical industry in collaboration. And we know from the chemical industry documents library at UCSF and papers that have been published from the tobacco industry, that the tobacco with the chemical and the fossil fuel industry have collaborated to set an agenda that undermines our ability to really understand the true impacts of these exposures and to address them. So one thing that we are doing is and we're happy to have people join us. You can check out our website, but we're launching an initiative to look at the true role of commercial determinants of health, and then to develop the remedies for that, which include, reducing bias in science, removing conflicts of interest in the government policy process, and highlighting where industry has been trying to influence the science and the regulatory process. So I think it's really important. I mean, people know, when in our surveys, and people know that the industry is, their goal is for profits. So we just need to mitigate that influence on the process and change the narrative. I just want to say, though, I was reading the old Surgeon General's. There's a new book out about the Surgeon General's report in 1964, and it sounds kind of nerdy, but the level of smoking at that time, I mean, I think they said it was a third of the GDP. I mean, we can do it. It's just how we have to highlight it and address it, unfortunately. So
yeah, I think if any of the listeners aren't familiar, for me, Merchants of Doubt by Naomi
oh
Oreskes,
yes, right,
a really compelling way to think about what you're talking about.
yes, and I think that's where we're like, I think now that we know enough empirically, our goal is to knit together and to kind of norm this in the conversation about science, because it's important. It's a factor in our health, so we should be addressing it.
I really appreciate your time. Thank you so much for being part of our series, and just say thank you and goodbye.
All right, well, thank you.
Yeah. All right, cheers.
Bye.